Alô, oi. Som. Eu vou ter que colocar esse microfone aqui, porque eu não consigo tirar o som dessa caixa. Então esse aqui é o que vai para a transmissão e esse aqui para o pessoal ouvir aqui, entendeu? Tá.
Caso precise, bastante funcionando. Obrigada. Tá quente aqui, né?
Oi, som.
Berta, faz uma coisa, fecha aqui no auditório e entra para que entre por... deixa... Esse aqui é o Dr. Henrique. Ele é brasileiro, muito enxa-saco. Dá um cafezinho dele lá embaixo, mas que tome ele lá embaixo o café e não sobe com o café aqui, porque senão vai matar. Tá bom? Tá, vai lá. Vamos? Tudo bem? Boa tarde a todo mundo. Hello. Eu vou... Isso aqui vai ser bem informal, tá? Aqui. Vai ser bem informal e vai ser em uma mistura de idiomas, porque tem gente que fala vários idiomas aqui. Eu sei que o povo que fala espanhol consegue me entender, porque quando eu falo portunhol, todo mundo entende. Não, por isso. Aí eu queria agradecer a todo mundo pela presença de vocês. Isso aqui faz parte do encontro que a gente tem de CLEOP. E a gente decidiu que essa sexta-feira pudesse ser aberta para que todo mundo que mora aqui em Porto Alegre pudesse participar também do encontro de CLEOP. Ontem a gente ficou sabendo que também está sendo transmitido por um canal no canal do YouTube do Instituto, então a gente e em Centroamérica também. Então isso é super legal porque todo mundo vai ter a oportunidade. Eles não vão estar entendendo o que eu estou falando também, mas não importa. Eu queria agradecer especialmente a quem veio de fora, a Cristina, que veio da Alemanha, do Euronet, a Ana Maria, que veio de Itália, chegou 2 dias que estávamos comendo aqui, bebendo, né? Bastante. E a todo o pessoal de Centroamérica, Latinoamérica que está aqui. Só para passar alguns recados, tinha aí no programa o Dr. Pedro Alarcón, que chegou até Guarulhos e voltou de Guarulhos, então não vai conseguir estar com a gente. E Peter Cole, que não conseguiu embarcar e ele vai chegar amanhã de manhã diretamente para a discussão. Mônica está a caminho de São Paulo, então acredito que a gente vai seguir o mesmo programa que a gente tem até agora, aí a gente para o café, enquanto isso dá tempo para a Mônica, que ela vai apresentar os dados do St. Jude, Stanford, e também vai apresentar os dados do COG, porque ela está com a apresentação do Dr. Pedro Alarcón. Eu estou em representação do Instituto aqui também, eu queria agradecer a toda a estrutura do Instituto que está me ajudando a poder montar isso aqui, que realmente é um desafio. E eu vou contar para vocês um pouco de que é CLEOP, principalmente, eu vou falar em português essa parte, porque principalmente para as pessoas do Brasil, o resto de Latinoamérica, todo mundo já sabe da história, e especialmente Cristina e Ana Maria já também sabem que estão fazendo parte. Mas o que é CLEOP? CLEOP é um consórcio latino-americano de enfermedades hemato-oncológicas pediátricas. Ele nasceu com o intuito principalmente de fazer trabalhos cooperativos em Latinoamérica. Fazer trabalhos que sejam de Latinoamérica, nascidos em Latinoamérica para nossos próprios países, né? E o propósito principalmente é aumentar a supervivência, como disse aí, a sobrevida das crianças com câncer em nossos países. Essa é uma publicação de Carlos Galindo, e aqui onde ele demonstra que principalmente os principais diagnósticos de câncer pediátrico são feitos em países de baixa e média renda, e que esses países não têm a mesma oportunidade de sobrevida que os países mais ricos. Então, baseados nisso e baseados nos dados que a gente tem, principalmente da OPS, que aproximadamente 17.500 novos cânceres vão ser diagnosticados em Latinoamérica por ano, e ao redor de 8.000 mortes por conta disso, é que a gente decidiu se juntar e fazer um consórcio latino-americano. Eu vou contar um pouquinho mais para frente a história. Mas a gente tem esse quadro que é um quadro do que acontece no Brasil com respeito à mortalidade e a disparidade com respeito ao que acontece no Brasil como um todo, no Nordeste e no Norte, é em parte o que acontece em nossa região de Latinoamérica, Hoje, como no Brasil como um todo, as neoplasias são a segunda causa de morte, né? Mas tem lugares ainda, como na região norte, onde as crianças morrem de doenças respiratórias, de doenças infecciosas, ou elas morrem e ainda a gente não sabe de que elas estão morrendo, que é pior. Então, a visão principalmente de CLEOP é poder trabalhar em detecção precoce, tratamento, reabilitação, formação de recursos humanos. Para quê? Para aumentar as chances de vida em crianças e adolescentes com câncer. Esse é um exemplo de um slide de Maurício, de Guatemala. O que aconteceu a partir da formação da OPCA. Então, eles tinham a diferença enorme entre sobrevida dos países de alta renda e os países de baixa renda. Em que ano que foi criado? Em 1998, se criou a OPCA, que é a Associação de Hemato-Oncologia Pediátrica de Centroamérica. E essa diferença se encurtou através dos anos com o trabalho cooperativo. Aí já deu uma escorregada no espanhol. Então, foi assim que CLEOP nasceu em 2013, na Argentina, na oportunidade de Daniel Frigeiro, que, em realidade, naquela oportunidade, era Eduardo Dibar, que era o chairman do GATLA e do Grupo Argentino de Tratamento de Linfomas e Leucemia, convidou algumas pessoas, entre elas, hoje estamos todos aqui, menos Agustín, mas convidou a Maurício, convidou a Juan de Peru, convidou a Agustín de Colômbia a apresentar o que estava acontecendo em cada um desses países referentes à oncologia pediátrica. Depois dessa apresentação de cada um, a gente se juntou e falou, bom, vamos fazer alguma coisa, vamos tentar fazer alguma coisa juntos em Latinoamérica com oncologia pediátrica. E foi assim que a gente começou a trabalhar, não? Nosso primeiro trabalho foi um pôster que a gente levou para o Childhood Adolescent and Young Adult Hodgkin Lymphoma. O terceiro foi agora em Washington. E levamos esse trabalho como primeiro desafio. Aí a gente continuou trabalhando por internet, continuamos trabalhando via Cure for Kids, continuamos trabalhando pelo telefone, a gente teve um encontro no meio do caminho, e aí foi que a gente decidiu organizar nosso primeiro encontro, o primeiro encontro de CLEOP, que foi em Uruguai, em abril de 2015. Nessa oportunidade, a gente convidou mais gente do Brasil, e nessa oportunidade se sumou o pessoal do México também, e continuavam as mesmas pessoas do Peru e da Argentina. E desse encontro surgiu uma publicação que se trabalhou durante o ano de 2015 para 2016, que saiu no Lancet Oncology, e que foi, digamos, o start para esse projeto continuar avançando e continuar crescendo. Aí veio o segundo encontro, foi realizado o ano passado, em 2016, em Lima, durante a SLAOP. Nesse encontro foi realmente onde nasceu toda a estrutura que CLEOP tem hoje. Tá? A gente teve 4 pessoas chaves nesse encontro, que foram Carlos Rodrigues Galindo, Mônica Merzel, Scott Howard e Valentino Conte, que ficaram com a gente e ajudaram a montar a estrutura que hoje tem CLEOP e a trabalhar juntos. Hoje, CLEOP está formado por um comitê executivo que tem representantes da Argentina, Guatemala, Brasil e México, um comitê interativo, uma secretaria-geral que momentaneamente ela está na cidade de Memphis, nos Estados Unidos, por uma questão que no momento não tinha estrutura, mas que a gente pretende mover ela de lá e talvez trazer ela, inclusive, para o Brasil. Um comitê científico formado por vários expertos e assessores como Valentino, Scott, e hoje a gente tem junto a Christine e a Ana Maria, que a gente pode falar que estão junto, e Peter Cole também estão como assessores externos. A ideia de CLEOP são esses gráficos que todo mundo gosta quando a gente apresenta, e é um pouco tem um CLEOP com uma coordenação central, a gente tem um CLEOP por país, e temos diferentes linhas de trabalho. Hoje eu já vou mostrar as linhas, mas a mais forte da gente é o protocolo de linfoma de Hodgkin, e a gente gostaria de integrar instituições que elas queiram trabalhar com um protocolo determinado que a gente tenha. Ou seja, não é necessariamente ela vai trabalhar sempre com CLEOP. Não, a mim me interessa Hodgkin, trabalho com Hodgkin. Me interessa o resto fazer com outro grupo, eu faço com outro grupo. Não tem absolutamente problema. E a gente com uma coordenação central. A partir disso, depois veio um passo bastante importante, que é a criação, nesse ano, foi em março, mais ou menos, que foi lançado o St. Jude Global, que é para levar ao mundo saúde. A saúde é uma aliança mundial verdadeira. E dentro dessa aliança mundial verdadeira, CLEOP está contemplado como ser um grupo novo e um grupo que pretende entrar junto com essa aliança global que St. Jude está fazendo. E aí vem esse encontro de hoje, que crescemos bastante. Hoje são 35 pessoas esperadas, teve algumas que tiveram alguns problemas para poder chegar, onde a gente tem gente de Centro-América, de Guatemala, a gente tem gente de México, Argentina, Brasil, Venezuela, Peru, e Chile virtualmente representada, porque o PINDA foi a última, digamos, união que a gente tem em um dos grupos de trabalho. E a gente tem o prazer de ter junto a Mônica, Peter Cole, Ana Maria Testi, Pedro Alarcón e Cristina junto com a gente. Tudo isso com o apoio da Sociedade Brasileira de Oncologia Pediátrica, e hoje representada pela Sônia, que é a vice-presidenta que está conosco. E obrigado, esqueci de te falar, obrigado, Sônia, por estar aqui. E com o apoio do Instituto do Câncer Infantil e Jazz Farmacêutica, que principalmente financiou as pessoas que vêm de Centro-América para que esse encontro possa ser realizado. Os focos de trabalho atualmente são os protocolos de linfoma de Hodgkin, com os mentores internacionais Mônica, Pedro e Cristina. E isso nasceu em Centro-América, e um pouco depois Maurício vai explicar de como nasceu esse trabalho com linfoma de Hodgkin e como se foram somando os diferentes países. E outro é o trabalho com leucemia promielocítica, representado no Brasil por Maria Lúcia Lee e Juliana Teixeira, e com os mentores internacionais, que são Raul Ribeiro, Valentino Conte e Ana Maria Testi. Então, isso é um pouco da história de como nasceu o CLEOP. Essa é a página web de CLEOP, vocês têm mais informações sobre quem faz parte e o que a gente está fazendo. E bom, espero que a gente possa ter uma ótima tarde. Espero que Mônica chegue a tempo para poder fazer as duas apresentações. E eu vou convidar a Ana Maria. A gente vai começar com a parte de leucemia promielocítica e depois a gente entra de cheio para a parte de linfoma de Hodgkin.
Bom dia. No, Okay, good afternoon. And first of all, please, I would like to thank the CLEOP group and for inviting me to this meeting, and especially in this beautiful country. It's my first time in Brazil. And I have to tell you that since Valentino Conter invited me to attend the CLEOP conferences, I really feel part of this group, and it's an honor for me. So I think that my next step is try to learn your language. Spanish language is not so different from my Italian language, and so I hope that I can do faster. But anyway, I'm going to present the pediatric experience in Italy on acute promyelocytic leukemia, and then give you the first results of the international ICC APL protocol. But just let me to summarize important point for APL. You know that management of APL for both adults and children has considerably evolved during the past 2 decades. And in contrast to other AML subtype, APL showed a big sensitivity to anthracycline when used as single agent for induction. But the advent of all-trans-retinoic acid and its inclusion in combinatorial regimens with anthracycline chemotherapy has provided the cure rate of approximately 75–80% of patients. However, this approach has a significant toxicity, severe myelosuppression, late cardiotoxicity, and also the rare occurrence of secondary leukemia. But more recently, the advent of arsenic trioxide and its use in association with ATRA, with or without chemotherapy, has further improved the outcome of the patients with APL, minimizing the intensity of chemotherapy and so reducing the serum toxicity and maintain the high anti-leukemic effect. Since 1993, the Italian cooperative group for adults hematological disease, the GIMEMA group, ideated this kind of protocol that we called AIDA 0493, combining ATRA and anthracycline. This was first a pilot study, but in association with the pediatric Italian cooperative group for hematology and oncology, it became a big multi-center study for the treatment of both adults and children with newly diagnosed APL. As you can see in this slide, the induction treatment consisted of ATRA at the dosage of 45 milligrams per meter square in adults and 25 for children, administered from day one to achievement of hematological remission and for a maximum of 60 days. ATRA was associated with idarubicin at this dosage, administered at the day 2, 4, 6, and 8. Induction was followed by 3 monthly consolidation courses combining anthracycline and other intercalating agents, such as cytarabine and etoposide and 6-thioguanine. At the end of consolidation, we evaluated the molecular response to treatment, and patients proved PCR negative were randomized to 4 different maintenance arms. 2 of them, including ATRA. One was standard chemotherapy as for ALL, and the other was no further treatment. But from February 1996, after a first analysis of the results, the 2 arms, not including ATRA, were closed, and patients were randomized only to the 2 arms, including ATRA. Each maintenance arm lasted for at least 2 years. Also, I want to specify that in this protocol, we did include intrathecal chemotherapy for the patients. For the other patients positive at the end of the 3rd consolidation course, we plan a salvage treatment. Here you can see the design of the protocol with the combination ATRA and idarubicin induction, the consolidation, the PCR evaluation at the end of the 3rd consolidation, and then the randomization for maintenance for those patients PCR negative at the end of consolidation. The main objective of this protocol was to assess the role of maintenance therapy for those patients in molecular remission at the end of the consolidation phase, and also confirm the results achieved in the previous pilot study, evaluate the rates of molecular remission after 3 consolidation courses, and induction ATRA-related toxicity. Here you can see the eligibility criteria, but patients ranging in age from 1 to 61 years with a morphological diagnosis of APL could start ATRA. Obviously, the confirmed genetic diagnosis based on RT-PCR or the presence of the 1517 translocation was mandatory requirement for continue the treatment. Other eligibility criteria include normal renal and liver function, a WHO performance status less than 4, no cardiac contraindication for intensive chemotherapy, and obviously a written informed consent. This protocol started on April 1993 and was closed on June 2000. 81 Italian hematological centers enrolled patients, but in particular 42 pediatric hematological centers diagnosed and treated patients with age less than 18 years. And again, the only difference between adults and children was the ATRA dosage, decrease in pediatric age at 25 milligrams per meter square day. Bone marrow was morphologically evaluated after induction before each consolidation course, at recovery from the 3rd consolidation every 3 months during the first year of maintenance, and every 4 months from the 2nd to the 5th year from the end of consolidation. Molecular response was evaluated at recovery from the 3rd consolidation course, and also at each morphological evaluation during maintenance, and at 5 years after the completion of therapy. Again, in 1997, we make an amendment to the protocol, and we suggest that in case of positive or double PCR during remission, a further bone marrow was required within 2 to 4 weeks to confirm the results. in the 42 pediatric center, 124 patients were registered. 110 of them resulted eligible to the protocol. And here you can see the reason for non-eligibility for the other 14 children. These are the patient diagnostic characteristics of the 110 eligible patients. You can see that the median age was 11.6, median white blood cell count was low, platelets count 10,000. Most of children showed the classical hypergranular form of APL, and also most of children had the BCR1 type of PMM RAR alpha transcript. In this column, I just summarize the induction result of this protocol. And as you can see, 96% of children achieved hematological CR. 4% died during induction, and no child showed resistance to idarubicin and ATRA induction schema. I compare this result with those achieved in pediatric age in the Spanish group. As you can see, they use the same ATRA plus idarubicin induction. And also, I compare this result to other two pediatric studies, German-Austrian Switzerland group and the French group. But in both these last group, they used ATRA and other chemotherapeutic agents for induction. Also, in the French group, the ATRA dosage was like in adults, 45 milligram. But as you can see, no difference in the induction results were observed among these four groups, and no child, again, was resistant to this induction chemotherapy. Also, the event-free survival and overall survival at 5 years was comparable among the four groups. And if we look at the toxicity of ATRA plus chemotherapy, you can see that the incidence of differentiation syndrome, but more of a pseudotumor cerebri and headache, was more higher in the French group, where ATRA was administered at a higher dose. And this is our Italian curve in our children. The overall survival is 89% at 10 years. This is the prognostic model ideated and proposed by Sanz, the Spanish group, that divided patients at that time in 3 risk categories according to white blood cell count and platelets count at diagnosis. And according to Sanz criteria, I divided our patients in the 3 risk group. And you can see that the outcome of patients at low or intermediate group is statistically better compared to patients at high risk. So white blood cell count at diagnosis seems to be really important in the prognosis of APL children. But in the next few years, other 4 studies were published, and all of them included treatment with ATRA and anthracycline. You can see that the results confirm those achieved in the previous study, but the Japanese group reported a better outcome of patients in terms of event-free survival and overall survival. And the difference in this study was that ATRA was used not only during induction, but also during consolidation. So with this background, on June 2000, the adult and pediatric Italian group for hematological disease designed this new protocol that we call AIDA 2000. We had two main modifications from the original AIDA protocol. As I can point the point, is this?
Yes.
This? Oh, okay. Two main modifications. First one was the risk-adapted therapy. Okay, patients at low and intermediate risk received a consolidation with omission of intercalating agents, like in the original Spanish consolidation study. And also, ATRA, according to the results of the Japanese group, was administered for all patients during induction, consolidation, and maintenance. And here you can see the design of both protocols, the original AIDA and the new protocol at the same induction treatment. Intensive consolidation in the AIDA 2000 was administered only to patients at high risk. For low risk, the other drugs except anthracycline were omitted, but ATRA was administered during consolidation in the new study for all patients. The molecular evaluation again was performed at the end of the third consolidation course, and patients proved PCR negative, received maintenance with standard chemotherapy and ATRA, and those still positive received salvage treatment. And this is the protocol study design with all the details of the drug. In this study, we used CNS prophylaxis with intrathecal methotrexate and prednisone only for children at high risk for each consolidation course. So the main aim of this study was to evaluate the treatment-related toxicity during ATRA, including consolidation, but also evaluate EFS, molecular hematological DFS, and overall survival for each risk group. The rate of molecular remission after consolidation in each risk group, and also induction morbidity and mortality after inclusion in this protocol of a prophylactic measure for differentiation syndrome and hemorrhagic complication. And these are the main supporting measure included in this protocol. We use prednisone at this dosage during induction in the attempt to prevent the differentiation syndrome. Also, you can see we specify platelets, fresh frozen plasma, packed red cell concentrate especially during the first 10 days of maintenance. And also, we recommend at earliest manifestation of suspected differentiation syndrome, the temporary discontinuation of ATRA, the employment of dexamethasone up to the disappear of symptoms and signs of the syndrome. And also, we gave the treatment for the pseudotumor cerebri. Eligibility criteria were exactly the same of the previous protocol. We just point out that the presence of additional cytogenetic lesion was to be considered, not exclusion criteria. And here you can see the result. 124 children were enrolled in the AIDA 2000 protocol. And I compare this series of patients with patients treated with the previous protocol. and you can see that the diagnostic characteristics are comparable for these two series. Only we could find a difference, no statistical significant for the median platelets count at the diagnosis between the last protocol where platelets count was 27.5 compared to the previous one. But in terms of type of M3, type of PMMR alpha transcript, and especially the risk category, we didn't find any difference between these two series. And here you can see the result of induction treatment. The AIDA induction confirmed to be very effective in our patients. This is the hematological induction rate, the early death rate, and again, no patients resulting resistant to idarubicin and ATRA combination. Here you can see the ATRA-related toxicity during induction, and you can see that with the supporting measure we had a decrease in ATRA-related toxicity. At the end of the third consolidation course, we make the evaluation of molecular response, and in spite of the decreased intensity of treatment for patients at low and intermediate risk, we have the same result. Most of patients became PCR negative. And this is the overall survival curve comparing patients treated with the previous AIDA protocol and those treated with the new protocol. And again, in spite of the decreased intensity in consolidation, we didn't observe any difference in the outcome. This slide is really more interesting because here is the overall survival for patients at low intermediate risk, and you can see that these patients show the same outcome. This is the survival curve for patients at high risk, and we could observe a better statistical outcome for patients at high risk. So for these patients, adding ATRA during the same consolidation courses improved the results. Also, failure-free survival, according to initial white blood cell count, improved for those children treated with AIDA 2000. And this is the cumulative incidence of relapse, and you can see that was decreased in AIDA 2000. These are the type of events after consolidation. You can see that we have 30 relapses, 19 hematological relapse, 14 in the previous protocol, and 5 in the last one. No child died in complete remission, and also we observed 4 therapy-related MDS, 2 in the previous protocol and 1 in the last one. So the message comparing these two AIDA Italian protocol is what you can see as follows. We confirmed in the last protocol the efficacy of AIDA induction, and also we improved the results even for both low and intermediate risk that achieved the same results with less intensive therapy, but the inclusion of ATRA in the consolidation phase improved the overall results for high-risk children. So with this background, especially with this good result achieved in Italy in pediatric age, but also considering the high cumulative anthracycline doses employed in both protocols, more than 500, 600 milligram per meter square, that we used in both protocols and could be associated with a real risk of lake cardiotoxicity, we designed the first multinational, multi-center childhood APL study 01, the ICC APL 01. And the main objective of this study was reduce the cumulative anthracycline dose. Also, we decided to deliver a risk-stratified treatment according to modified SANS criteria, so according to initial white blood cell count, and to monitor the minimal residual disease by RQ-PCR for PMMR alpha and try to adjust the treatment according. The endpoints are summarized in this slide: overall and event-free survival, achievement of molecular complete remission, duration of remission, rates of molecular and frank relapse, and also toxicity and supportive care requirement. Inclusion and exclusion criteria were almost the same as for the previous protocol. In this protocol, this didn't happen in Italy. Patients younger than 21 years were treated in our country. In Italy, we decided to maintain age less than 18 years. And this is the protocol. Okay. Induction, you can see, doesn't work. Okay, thank you. Here. Okay. You can see the patients were divided in two risk groups according to white blood cell count, and the induction was exactly the same as for the AIDA protocols. Patients at standard risk received two consolidation course. And at the end of the second consolidation course, we performed the evaluation of molecular response, and those patients proved negative received maintenance. For the other patients still positive, they received a third consolidation course as for those patients at high risk. And again, we make a new evaluation of molecular response, and patients negative receive maintenance, while those patients still positive, for these patients we plan a salvage protocol including arsenic. And this is the distribution of patients by country and also by cooperative group. We registered 240 patients, and here you can see the baseline features of these patients. I want to have your attention regarding the median white blood cell count at diagnosis. You can see 6.1 was higher compared to the median white blood count of the two previous protocols. And so consequently, the group of patients at high risk had higher incidence. And these are the results. 195 are evaluable for induction response, 97% achieved hematological remission, 3% induction, that 18 patients relapsed with this different distribution between hematological and molecular relapse. 16 out of the 18 patients were salvaged with ATO treatment, and also in this group we had one therapy-related AML. This is the induction toxicity of this study that was quite similar to the toxicity observed in the last AIDA protocol. And this is the MRD monitoring and exactly the percentage of patients still PCR positive at the different time point. As you can see, most of patients become PCR negative after the second consolidation course, but few patients still continue to respond with the third consolidation course. And this is the overall survival of this group. And also in this protocol, we didn't observe any statistical difference between children at high risk and those at low risk. This is the event-free survival, and also for the event-free survival, no statistical difference in the two risk categories. Okay, now I try to compare the two risk-adapted protocol, the previous AIDA 2000 and the last ICC APL study 01. But the main important difference between these two protocols was the cumulative anthracycline dose that was really very high in the previous AIDA study and was decreased in this last study, not only for patients at standard risk, but also for patients at high risk. And if I compare the characteristic of these two series of children, again, you can see that in the last protocol we had a higher white blood cell count and a higher number of patients at high risk. But this is the curves for patients treated with ICC APL study and the GMEMA study. And you can see that in spite of decreasing the dose of anthracycline, we didn't have any difference in the outcome. So the comments for these first results of this protocol are that this is the largest pediatric multinational multi-center APL cohort of children homogeneously treated with a specific risk-adapted protocol that was based on extended ATRA and reduced anthracycline chemotherapy. And the results are comparable to those achieved in the previous Italian AIDA 2000. So what will happen for the future? Okay, we have this good background, but also we now know that ATO is the most effective single agent for APL. And alone or in combination with ATRA or low-intensity chemotherapy result in a greater efficacy, but and also less acute toxicity. Two randomized studies for adults at standard risk combining ATO and ATRA are now published, and both demonstrated the better outcome and the more manageable toxic events in this group of patients. Experiencing children as a first-line protocol are still scarce, but studies from China showed that there is a minimal toxicity and favorable outcome, especially for standard risk patients. So our future protocol that we will call ICC APL study 02, again will be a multi-center study, but combining ATO and ATRA for newly diagnosed APL. And this is the outline of our next protocol. And you can see that we want to use the combination of ATO and ATRA for patients at standard risk. This combination will be repeated also during consolidation therapy. And for those patients at high risk with higher white blood cell count, we need to add GO, or if we are just waiting to know if GO will be available for each center, and but if GO will be not available for everyone, I think that anthracycline therapy should be administered for these high-risk patients during induction. And our objective will be to evaluate in an international pediatric study the safety efficacy of this combination for standard risk and this other for high risk. Also to try to reduce the morbidity and toxicity and improve the quality of life for these patients. And also other objective such as the clearance kinetics of MRD in this study. And finally, but not less important, to compare the duration of hospitalization and the quality of life with those of the previous AIDA protocol and the ICC APL on 1. These will be our endpoints, and also the inclusion criteria, quite similar to the previous inclusion-exclusion criteria, but we had to add that since ATO can prolong the QTC, we had to exclude patients with severe significant arrhythmias. We need at least 6 standard patients at a standard risk, 40 at high risk. We hope that almost 100 institutions across different European and non-European countries participate in the study, and this is the recruitment period. So this is my last slide, and I want again to thank you for the attention, again to thank the CLIOP group and this wonderful meeting in Porto Alegre. Thank you very much.
Thank you, Hannah, for this wonderful presentation. I don't know if someone got any questions, something that maybe a comment, Danielle or something. Someone?
Ana Maria, what's the rescue therapy for the patients that could not enter remission or relapse?
Okay, Federico, this is very good question. Okay, I think that it will depend on the duration of first molecular remission, because those patients with late relapse continue to respond to arsenic trioxide. But for those patients with early relapse, I think that chemotherapy has to be utilized, probably in combination with all-trans-retinoic acid. But it's really a good question. During last summer, I don't know if you could see the publication with a group of colleagues from United States, from Italy, from Germany. We tried to make some issues how to manage patients with relapse. And we try to specify that the duration of first remission is important. Also type of relapse, because molecular remission, if you can monitor the MRD and you are sure in 2 consecutive bone marrow samples that this patient is in molecular relapse, this kind of relapse is more manageable compared to patients with a frank relapse. Okay. You're welcome. Yes, please.
Do you have any guidelines for the complications in the brain with seizure, imaging-wise? How do they manage? Do they do emergency CT? Do they do emergency MRI? How this is managed?
Do you mean if a patient showed signs and symptoms of a pseudotumor cerebri? Yeah.
It's, for me, as a radiologist, I see in São Paulo, the Institute, some patient with, let me call it leukemia. I don't want to go different type because it's not my subject. We see patients that arrive at the emergency room in different stage of treatment, and they may have seizure, they may have funny headache, they may be behaving not normal, and since you show some of this, I think the percentage is the same. I think we are seeing more osteonecrosis without clinical findings, because in some of them we do MRI, we find bone changes. Plain film are normal, bone changes are seen on MRI. But what's the protocol, the guideline that you design, or you don't have any guidelines?
I'm sorry, we still don't have any guidelines regarding this problem, but you're right, it's an important problem. Also, we could observe some osteonecrosis, and this is another important point, since we introduced dexamethasone for children showing this kind of complication. So in this last protocol, we decided to reduce the total amount of prednisone for our patients, and to decide to use prednisone, especially during the first 10 days of treatment, where such complications are more frequent. But good questions, thank you.
I have a question here from Maria Lucia. She's back home.
Okay. Okay.
And she's asking, how do you intend to evaluate induction response, and in which moment?
Also very interesting question. Okay, you mean for the last protocol? Okay, we supposed to perform the first bone marrow evaluation after a minimum of 28 days. Okay, but both the drugs can be continued up to 60 days. So if the morphological evaluation is not satisfactory after 28 days, we plan to continue the treatment and make other evaluation during these further days. It's difficult to have a good evaluation of the morphological response when you use this differentiating agent. But ATO is different from ATRA, because with ATO plus ATRA, in adults, we could see some molecular response after induction, many molecular response. When you use ATRA in chemotherapy, most of patients are still molecular positive after induction. So this is not the good type of response evaluation. Also in the new protocol, we want to perform the most important molecular evaluation after 3 consolidation courses.
Okay, thank you. Any more questions?
Which is the rate of bone marrow transplantation that you have?
Okay. Very low, as you could see, because most of the patients are in molecular complete remission after the end of consolidation. Bone marrow transplant was included in the salvage treatment for the first protocol, AIDA 0493. but the use of bone marrow transplant was really decreased in the next two protocols, especially in the last one, because most of these children, as I showed you, 16 out of 18 could achieve a good response with salvage treatment, including arsenic. So the role of stem cell transplant really decreased during these years. And if we want to go toward a chemotherapy-free protocol, I think that we really need to decrease the stem cell transplant for this disease. In my personal experience, I have some children who relapse after the last protocol treated with arsenic trioxide. They didn't perform stem cell transplant because they showed a rapid molecular response, and they are still alive without transplant and in molecular remission. This is my hope, to really decrease the use of stem cell transplant in this disease. Thank you.
Any more questions? Thank you very much.
Thank you to you.
Fala dele em espanhol. Espanhol, não portunhol. E ele vai falar bem devagar, tá? Para que todo mundo possa entender. Isso é o charme de óptica. A gente se conheceu em 2013. Foi amor à primeira vista. Não me escutem aí, mas graças a ele a gente conseguiu trazer o protocolo de linfoma de Hodgkin para o Brasil. A gente levou ele para a Argentina, a gente levou ele para o México e a gente hoje está fazendo o protocolo de linfoma de Hodgkin de México até a Argentina. Ainda faltam alguns países se juntar, mas a maioria dele provavelmente conhecem a voz dele nas discussões das terças-feiras via Cure for Kids. Esse é o Maurício. E ele vai apresentar para nós os dados da óptica. Tá? Muito obrigado.
Bueno, buenas tardes. Por favor, cierren los ojos y así pueden reconocer mi voz y me siento en confianza porque sé que nos hemos juntado en algún momento durante las reuniones de Hodgkin. Alejandro, no me diste el... Perdón. Este es, ¿verdad? Perdón, Ale. Puntero ahí, ok. Gracias, gracias Ale. Bueno, yo creo que nos conocemos y primero quiero agradecer a Ale por la increíble organización, ¿verdad?, que has tenido con este evento y con todos nosotros. Yo quiero contarles un poco de AOPCA, un poco de la historia de cómo es que 7 países muy pequeños empezaron a creer que se podían hacer las cosas diferentes y que la única forma de que un país muy pequeño pueda hacer algo es juntando varios países para poder aportar algo diferente que es solo tratar. Entonces, para mí el título de colaboración es un paso adelante, es la única forma en que Latinoamérica puede aportar muchas cosas. Voy a repetir algo que él le dijo, pero que es muy importante. El 80% de los niños con cáncer viven en países pobres o de bajos recursos. La mayoría de los países como en Europa o en Estados Unidos que tienen los recursos es donde menos niños hay y que necesitan tratamiento. Y la supervivencia aún en algunos lugares puede ser de 0. Y por eso que lo que hagamos nosotros puede ayudar a compartir a otros lugares como África, Asia, que necesitan tal vez un poco de ayuda de países que sean parecidos. Esta es la realidad, al menos de Centroamérica, ¿verdad? Tenemos pacientes desnutridos, que tal vez en Europa o en los Estados Unidos no hay muchos. Tenemos mucha enfermedad avanzada, ¿verdad? Llegan ya avanzados, tenemos diagnóstico tardío, y la pobreza, que es parte de un problema grande para nosotros. ¿Por qué? Porque el papá llega al hospital, le decimos que el cáncer se puede curar, pero tiene 4 hijos en otro lado, donde tiene que regresar a trabajar, y por eso prefiere ir a trabajar y no curar a este niño. Entonces el abandono para nosotros en países en Latinoamérica es muy grande, y es un punto que tenemos que tomar muy en cuenta, y en AOPCA lo hemos hecho desde el inicio. Para presentarles a ustedes a AOPCA, somos 7 o 8 ahora, ¿verdad? Contando Haití, porque ya trabaja con AOPCA, pero este es Guatemala, de donde yo soy. Luego Salvador, Honduras, Nicaragua, Costa Rica, Panamá, República Dominicana y Haití aquí, perdón que no estuvo, pero ya Haití trabaja con nosotros. Somos 7 países, 8 países juntos, trabajando desde 1998. El sueño de que Latinoamérica trabajara junto viene de hace muchos años atrás, no fue una idea del 2013-14. Muchos conocerán al profesor Macera de Italia, que él empezó a tener la idea de trabajar con Nicaragua. Empezó con ellos a hacer algo porque le quería ayudar. Y luego, después de eso, él pensó, ¿por qué no me llevo a Milán algunas personas de toda Latinoamérica y tratamos de hacer algo juntos? Llevó gente de Cuba, de Bolivia, de Perú, Centroamérica, y lo hizo por varios años tratando de que se juntaran, contaran su historia y que se juntaran a hacer algo diferente. Y de eso también interviene St. Jude, que dice, bueno, nosotros también, a partir de una experiencia de un niño salvadoreño que llega a St. Jude, ellos, los papás, instan a St. Jude a que ayuden también a curar a niños, no solo de los Estados Unidos, sino también de otros lugares, y así empezó Guatemala, El Salvador. Y en 1998, después de varios años de estar yendo a Milán, se forma lo que es AOPCA, la Asociación de Hemato-Oncología Pediátrica de Centroamérica, que en el 2001 estuvo Panamá, 2006 República Dominicana y Haití, y ahora son más manos juntas trabajando por los niños. Entonces, esa es la historia de alguien que quería hacer algo por los niños en Latinoamérica. Centroamérica empezó a hacerlo, lo creyó y de verdad que hizo la diferencia para esos niños. Ahora voy a hablarles un poco de lo que nos interesa a muchos acá, que es del linfoma de Hodgkin, específicamente cómo eso hizo el cambio. Y la verdad que tenemos que reconocer que a nosotros no nos gusta a veces ver el pasado, pero es muy importante saber de dónde venimos para poder saber a dónde vamos y qué cambio vamos a hacer. Entonces, ya desde el 97 empezó Nicaragua a publicar lo que ellos hacían. Ellos no tenían radioterapia, así que tuvieron que empezar a usar drogas altas para poder empezar a curar a los niños, porque antes de eso se morían todos los pacientes. Cuando en Europa ya tenían un 70% de sobrevida, nosotros en nuestros países se morían todos los pacientes. Era increíble ver eso. Aquí no era cuidar la toxicidad, aquí era curar lo que se podía, es el primer paso. Y bueno, empezamos a tener 48 pacientes, eso fue lo que se empezó a reportar. ¿Y qué se hizo? Y los resultados, al menos ya sabíamos dónde estábamos, ya habían resultados, aunque la toxicidad definitivamente era muy alta. Pero ya se curaban niños, ya podíamos demostrar que había un resultado. Entonces, eso es lo primero. Aquí, después de esto, inicia AOPCA. Esto fue solo Nicaragua. viene a OPCA y se junta. Y de 48 pacientes, empezamos ya a tener 216 pacientes juntos. Lo pudimos publicar y empezamos a tener resultados, aún muy parecidos a los anteriores porque no habían muchos cambios, pero ya se tenía historia, ya se tenía resultados y eso empieza a llamar ayuda y a llamar trabajo. Si ustedes se dan cuenta, los pacientes de estadio 4, la sobrevida verdaderamente estaba muy baja, aún los estadios 2 o 1 estaban bajos, pero ya había resultados y ya se curaban niños, que eso era algo importante. A raíz de todo eso, San Jude empezó a ayudarnos a poder juntarnos. ¿Cómo poder ayudarnos? ¿Cómo poder comunicarnos más? Y fue lo que usamos ahora, que es el Cure for Kids. Empezamos a tener reuniones donde podíamos presentar imágenes, donde podíamos presentar los casos, donde podíamos levantar la mano si queríamos consultar y empezamos a ver que la gente empezó a exponer sus dudas, a compartir sus problemas y es mucho más fácil tomar responsabilidad en grupo que hacerlo uno solo. Poder decir qué piensan ustedes, me ayudan con esto y tener opiniones. Enrique nos ha ayudado muchísimo ahora con lo que es la radiología. Entonces empezamos a ver que los niños tenían un mejor tratamiento. ¿Por qué hacemos todo esto? ¿Quiénes son los principales? Son los niños y ellos empezaron a tener una diferencia de tratamiento. Ya no era solo curarlos y que dentro de 10 años estuvieran estériles, con problemas. No, ahora ya queríamos curarlos y cuidarles también su vida futura. Entonces empezamos en el 2004, que fue cuando yo llegué a trabajar en lo que era el linfoma de Hodgkin, a partir ya por grupos, que es lo que actualmente estamos usando y vamos a trabajar el fin de semana para ver si seguimos haciendo lo mismo. Pero ya teníamos un orden, ya teníamos una historia, ya podíamos decir, ya podíamos comentar, ya había experiencia. Y empezamos en el 2004 al 2012 a usar lo que ya todos conocíamos, pero de una forma ordenada. Ya no era solo de démosle a ver cómo le va y no, ya no. Ahora sabíamos que podíamos hacer una evaluación temprana, que está demostrado la intensidad de la quimioterapia. Y por primera vez en Centroamérica, donde se morían todos los niños antes del año 2000, empezamos a decir, no demos radioterapia a los que tienen remisión completa. Todo el mundo nos asustamos. No, ¿cómo vamos a quitar la radioterapia? ¿Se van a morir los pacientes? No, ya no. Ahora ya ya no estábamos solos, Mauricio Castellanos, Armando Peña de Honduras, no, ahora teníamos ya mentores, doctor Pedro Alarcón, Mónica Mesger, ya trabajábamos juntos porque vieron que podíamos hacer algo diferente y empezamos a diseñar esto, aunque todavía estaba alto la dosis de radioterapia, pero ya era algo. En el riesgo intermedio, las dosis, a pesar de tener 20, 25, ya habían bajado, porque antes cada quien hacía lo que se le ocurría. Lo que pensaba que era bueno lo hacía. Ahora ya no, todos íbamos a hacer lo mismo. 7 países juntos haciendo lo mismo. Y en ese tiempo usábamos el Stanford 5 modificado para los alto riesgo, pensando en que esto eran 12 semanas, el paciente no podía abandonar porque tenía que venir todas las semanas y esto nos permitía curar más pacientes, siempre haciendo la evaluación. De 49 pacientes, de 219 pacientes, pasamos a más de 400 pacientes juntos, haciendo lo mismo, tratados igual, pudiendo analizar nuestros datos, ya no lo que hacen en otros lados, sino lo que hacíamos nosotros, pensando en la desnutrición, en la pobreza, en el abandono, y ahora sí podíamos nosotros hacer algo diferente. Y entonces puse este slide más que todo por la cantidad de pacientes que ya nosotros teníamos como grupo. Ahora ya cuando íbamos a algún lugar ya podíamos presentar algo así, ya la gente ya nos platicaba, doctor, ¿cómo hacen ustedes con esto o lo otro? Gente de hacia otros lados para comparar. Entonces los resultados empezaron a cambiar. Si ustedes se dan cuenta, estos son años de seguimiento. Ya podemos decir, sí podemos hacer las cosas bien, podemos cuidar los datos, podemos ver, y esto es la sobrevida de lo que es el bajo riesgo. Y esta curva azul, que nunca sale en las curvas de Europa ni de Estados Unidos, es el abandono como evento. Para nosotros, si un paciente abandona, se muere. Lo tomamos como que murió. Entonces, eso es un evento para nosotros. No para otros lugares, pero sí para nosotros. Y este es el event free y este es el overall. Resultados de bajo riesgo sin radioterapia, wow, mejor. La verdad que estábamos ya mejorando. Luego, igual para el riesgo intermedio, igual los años de seguimiento. Y el abandono aquí era un problema, es un problema. Porque aquí estamos hablando no solo de Guatemala, sino de toda Centroamérica. En Guatemala tenemos muy bajo abandono, porque encontramos que dándoles el pasaje para la gente, dándoles comida para llevar a su casa, dejaban de abandonar. Y la educación, repitiéndole, se va a curar, vale la pena luchar por él, aquí está su comida, llévela para su casa, le pagamos el bus, el transporte, esto ha ido bajando. Entonces, la verdadera, el event free del riesgo intermedio, que para nosotros es todos los pacientes que tienen bulky, es bueno. Andamos por esto. Entonces, aquí nos dimos cuenta que algo que teníamos que pelear era por el abandono, y hacia ahí nos concentramos y hicimos cosas. El Stanford 5 no nos fue como queríamos, no nos fue los resultados que queríamos, porque si ustedes se dan cuenta, sigue abajo los estadios 4, estamos muy bajos en eso. Entonces dijimos en el 2009, hay que cambiar. Ahí fue la primera vez que conocí a Christine, porque en una sesión de Cure for Kids empezamos a discutir qué hacemos. Stanford 5 no nos funcionó como queríamos, estamos mejor que antes, pero no lo que queremos. Queremos mejorar aún más. Y ahí surgió la historia del OEPA COPDAC. ¡Wow! Todos se asustaron. No, OEPA, no, es muy intenso. ¿Qué vamos a hacer con eso? Les voy a contar la historia de lo que nos pasó. El Stanford 5 falló porque no usamos la droga original. Se usó la ciclofosfamida, por eso era Stanford 5 modificado. Y esto fue publicado por Mónica, porque ellos también lo hicieron en St. Jude, en Dana-Farber y en Stanford, hicieron lo mismo y les fue igual que a OPCA, igual, les fue mal. Miren cómo iba esa curva. Entonces, juntos dijimos, paremos el Stanford, ¿ok? Pero nos fue igual. O sea, no fue culpa de Centroamérica, no manejamos mal los pacientes, no, era la droga lo que estaba mal. Por eso es que uno no puede solo cambiemos y probemos esto, yo lo leí, no. Hay cosas que hay que tener mucho cuidado antes de tomar decisiones. Esto es lo que estamos usando actualmente, creo que todos nosotros. Brasil, Argentina, Venezuela, ¿verdad? Perú, estamos usando esto. 4 ciclos de ABVD, si remisión completa, no radioterapia, y si remisión parcial, 20 grays a las áreas involucradas solo en la evaluación. Por eso es tan importante la revisión centralizada, Enrique. Es por eso. Porque si nosotros decimos que el paciente está en remisión completa, no radioterapia. Y si nosotros decimos que hay remisión parcial, ¿dónde? Ahí le vamos a dar radioterapia. Entonces, si no estamos seguros, vamos a dar radioterapia o vamos a dejar de dar radioterapia a pacientes que lo necesitan o que no lo necesitan. Entonces, por eso estamos aquí en Porto Alegre, para decidir esto, porque aquí lo hacíamos nosotros. ¿Qué piensas tú? A mí me parece que está en remisión completa. Ah, ok, muy bien, pero no es lo mismo que tener a alguien que nos diga, no, aquí no me parece esto, o no está bien esta imagen, repítala, o hagámoslos todos iguales. Y aquí cambiamos al riesgo intermedio, le pusimos la evaluación temprana. Lo que hacíamos antes en el cuarto, lo bajamos al segundo y también quitamos la radioterapia. Todos se asustaron. ¿Por qué? Porque el bulky en Centroamérica, por lo menos, son unas masas de este tamaño. No son pequeñitas de 6 centímetros. Son grandes masas que uno se asusta y dice, ¿le voy a dar más radioterapia o ya no le doy aunque tenga bulky? A nosotros nos funcionó que si estaba en remisión completa, no radioterapia, no un boost, no nada. Íbamos a hacer esto. Y bajamos la dosis. ¿Cómo nos fue? Eso es lo interesante, porque aquí sí hay cambios muy importantes de toxicidad. Estos son los resultados que necesitan más tiempo de seguimiento, por supuesto, pero que se ha mantenido el bajo y el intermedio Aquí el abandono está incluido, ¿ok? Por eso es que puede bajar un poco esta curva. Pero los resultados de por sí, quitando la radioterapia, donde en el bajo riesgo, el 90% de los pacientes tienen remisión completa, o sea, no reciben radioterapia. Y en el riesgo intermedio, donde el 33% no reciben radioterapia, y tal vez ya con Enrique va a ser el 40%, o tal vez va a ser el 20%, porque estamos muy optimistas de decir la definición de remisión completa, esto va a mejorar aún, porque va a ser diferente. Pero estos son los resultados actuales, sin radioterapia y con dosis bajas de radioterapia, y solo a las áreas que son positivas en la evaluación, ya no al diagnóstico. O sea, menos toxicidad, mejor calidad de vida. Entonces, ¿qué pensamos? Bueno, Christine, conocemos a Christine, a Dieter. ¿Cómo les fue a ellos? Ellos ya publicaron esto y les fue bien, compararon sus curvas, nos enseñaron que OPA y OEPA les iba igual, y eso nos va a hablar Christine después de mi plática, pero dijimos, ok, intentemos. Todos preocupados. Desnutrición, pacientes tardíos, con diagnóstico tardío, eso no lo miran en Alemania. ¿Nos va a ir bien? Todos preocupados, pero creímos que era lo mejor. Entonces dijimos, 2 OEPAs, evaluamos. Nosotros no nos atrevimos a quitar la radioterapia porque no tenemos los métodos como ellos evalúan la remisión completa. No tenemos PET. Nosotros en Centroamérica no tenemos PET. Solo CT. ¿Es tan confiable como el PET? Podemos decir que si la CT nos da remisión completa, ¿es completa o no? En este momento dijimos, no tenemos que cambiar muchas cosas, porque lo que queremos es seguir curando niños. Vamos despacio, demos tiempo. Entonces, aquí empezamos entonces a ver, estos son 217 pacientes solo de alto riesgo, no bajo riesgo, intermedio, no, son 217 pacientes solo de high risk. ¿Se recuerdan cómo eran las curvas antes? Que el estadio 4 andaba por el 30%. Actualmente ya mejoró. Mucho comparado. Pero sabemos que aún podemos hacerlo mejor. Y es por eso que estamos aquí con Christine, con Mónica, venía el doctor de Alarcón para saber cómo vamos a mejorar esto. ¿Sí? ¿Cómo lo vamos a mejorar? Porque el estadio 2B nos va muy bien, pero el 3 y 4 todavía creo que podemos mejorarlo más. A ellos les va mejor. ¿Por qué será? ¿Qué estamos haciendo mal? ¿Cómo podemos mejorar? La revisión centralizada de imágenes, la revisión centralizada de patología, porque a veces uno se confunde de diagnóstico, si no lo hace bien, y tal vez por eso es que no nos va como a ellos, por ejemplo. Somos muchos países y en algunos sí tenemos inmunistoquímica y en otros no tenemos inmunistoquímica. ¿Qué vamos a hacer con los que no tienen? ¿Qué tal si es un predominio linfocitario pero no le hacemos CD20? Eso no es confiable. ¿Nos vamos a ayudar? Yo, Guatemala, ayudo a toda Centroamérica a revisar la patología. Yo, el centro de Brasil, les ayudo a revisar la patología a los que no tienen todo esto. Hagámoslo juntos. Los niños lo merecen. Ellos van a salir beneficiados. Entonces los resultados ya son buenos, de verdad. Y así Argentina, México, Perú, ya tenemos los mismos resultados. Y ahí fue donde nació todo esto. Así fue. Le presenté a David Verón los datos, nos invita Daniel a Argentina, conozco a mi amigo Alejandro, de ahí empezamos a trabajar con Iván y Juan, con todo el mundo, luego fueron Venezuela, que de verdad un trabajo increíble. Entonces, Brasil ahora, increíble. Esto es un sueño que tenía el profesor Macera en los años 84, 85, y no pudo hacerlo en ese momento, no pudo. No eran las personas, no era el tiempo. Ahora llegamos a esto. Estoy seguro que cuando el profesor Macera vea esto va a decir, wow, eso quería yo para los niños, que trabajaran juntos, que ya no dejen de pensar quién es el más importante, soy yo. No, no soy yo, es el niño. Entonces no importa si estoy yo primero, segundo, tercer autor, no. Lo que importa es los resultados. Entonces empezamos a creer en esto. Empezamos a creer en esto y ahora estamos aquí todos los que estas estrellas marcan. Ya tenemos años trabajando juntos, no es que vamos a probar a ver si nos va bien, no. Ya hemos demostrado que trabajamos juntos, pero que podemos mejorar. Ahora es cuando de verdad debemos de comprometernos, porque si vamos a iniciar un nuevo protocolo de APL, de Hodgkin, vamos a hacerlo bien, porque imagínense que en Hodgkin esperamos, siendo pesimistas, 800 pacientes al año. 800 patients per year. ¿Qué tal si no tomamos bien los datos y no llenamos bien las hojas y no queremos reunirnos? Vamos a perder esa información. No, ahora no. Ahora creo yo, de verdad, que lo vamos a hacer bien. Que vamos a hacer un grupo como lo es Euronet, como lo es el COG. ¿Por qué no? Pero sí tenemos que comprometernos a hacerlo bien. Eso tiene que cambiar, esa cultura nuestra que a veces, ¿llenaste los datos? No, no pude. El último día, metiendo los datos. ¿Y cómo sé yo si me puso verdaderamente el dato correcto? Vamos a tener que ir a los centros, a ver cómo llenan, o sea, va a haber muchas cosas. Y por eso es que San Jude aquí tiene un papel importante, porque nos va a dar la estructura para hacer esas cosas. Entonces, para terminar, ahora tenemos oportunidades que antes no teníamos. Podemos hacer estudios clínicos con diferentes brazos. El objetivo principal de este nuevo protocolo de Hodgkin es que ningún paciente se quede fuera de un protocolo estandarizado. Quiere decir que si yo solo tengo ultrasonido y radiografía de tórax, porque soy muy pobre en mi centro, le vamos a dar una opción de trabajo. Hace esto. Si yo tengo tomografía, este es el protocolo. Si yo tengo MRI y tengo PET, esto vas a hacer. Así todos podemos trabajar juntos en el mismo protocolo, pero dándole la oportunidad a todos. No es que si no tenés PET, no puedes venir con nosotros. No, todos podemos trabajar. Y lo mismo trabajaron en APL. Todos podemos trabajar. Estudios randomizados. ¿Se puede hacer eso en Latinoamérica? ¿Cómo va a ser? Son éticos por una razón. Argentina, por ejemplo, en Buenos Aires tiene PET. Guatemala, Centroamérica solo tiene CT. Después de 5 años nos vamos a juntar con David y vamos a decir, ¿cómo te fue a ti? ¿Cómo te fue en la remisión completa? ¿Cómo te fue en el bajo riesgo usando PET? Me fue así. Yo solo usé tomografía y me fue igual. ¿Vale seguir usando el PET? ¿O tenemos que exigirle a todos PET? ¿O qué vamos a hacer? Esos son estudios randomizados éticos, porque se hicieron porque yo no tengo PET y él sí tiene, así que no es que estemos mal. Trasplante con quimioterapia. Aquí está Oscar. Oscar va a trabajar en lo que es el rescate de los pacientes con Hodgkin. Si ustedes tienen trasplante, háganlo. Ahora, yo no tengo. ¿Qué voy a hacer? Juntémonos los expertos. Díganme qué es lo mejor. ¿Cómo vamos a tratar a nuestros pacientes en los cuales yo no tengo trasplante y tienen una recaída temprana o una progresión de enfermedad? Entonces, eso, ya tenemos datos y lo vamos a hacer. Y esto es lo más importante. Más niños tienen acceso a un tratamiento comprobado y estandarizado. Ya no es, yo hago lo que quiero y tú haces lo que quieres. ¿Yo hago qué? No, ese no me gusta. A mí me gusta el que traje donde estudié. No, todos iguales. Vamos a aprender a hacer las cosas como debe ser. Si decidimos que sí, vamos todos iguales. Y eso, de verdad, en 5 años, estoy seguro que vamos a curar más niños con menos toxicidad, pero vamos a aportar algo para la gente que vive como nosotros, que los van a poder usar. Así que yo quiero de verdad agradecer a toda la gente que ha trabajado en esto, a ustedes por estar aquí. Espero que mi español haya podido llegar, ya los conceptos han llegado a ustedes. Y yo estoy 100% convencido de que CLEOP, como grupo, va a ser una diferencia impresionante. Solo debemos de confiar y trabajar. Y sé que los niños van a ser los más beneficiados. Y eso lo queremos todos, estoy seguro, todos. Así que muchas gracias por el tiempo. Bueno, interesante porque por el tiempo. Cuando nosotros cambiamos al OEPA, tuvimos en los primeros pacientes, tuvimos mucha muerte por toxicidad. Y aprendimos entonces que el primer OEPA teníamos que tener al paciente cerca, porque la desnutrición o cualquier cosa que él traía antes lo predisponía a hacer más fácil una muerte por toxicidad. Solo aprendimos eso. Solo dijimos, este paciente se queda en el albergue, no en el hospital, en el albergue, y lo vemos siempre, y después de ahí no volvieron a morir pacientes. Y compartimos eso con Argentina, cuando ya lo sabíamos y ellos no tuvieron muertes por toxicidad. Y entonces, por eso es que ahora el OEPA confiamos en que lo podemos usar, pero fue por toxicidad porque no sabíamos cómo, que ese primer OEPA en un paciente desnutrido, en un paciente con infección, era de tenerlo muy cerca porque sí es intenso, ¿verdad? Entonces, después de aprender eso, ya no tuvimos ese problema, ya no hubieron más muertes por toxicidad.
El número de pacientes con low risk es muy bajo comparado con intermediate risk, high risk.
Sí.
¿Qué estrategias vamos a usar? ¿Protocolo para diagnóstico?
La verdad que es una pregunta importante desde el punto de vista de que cada país tiene su propio problema y lo que tenemos que hacer es poder educar a la gente que el cáncer sí se cura primero y luego trabajar con estudiantes de medicina, trabajar con esta gente que tiene el primer contacto para que nos lo mande rápido, porque nosotros de bajo riesgo tenemos muy pocos pacientes. De los 400 pacientes son 48 pacientes de bajo riesgo, porque miran el ganglio pequeño, le dan antibiótico, se va con otro médico, le dan antibiótico y así crece, y cuando llega con nosotros ya es riesgo intermedio mínimo, ¿verdad? Aunque la sobrevida de riesgo intermedio estamos en 90%, todavía lo podemos recuperar, pero es educación y cambio de mentalidad.
Una última pregunta.
Sí.
El 90% de los pacientes en Guatemala son Epstein-Barr virus positivo y la edad de los niños es más baja.
Sí.
¿Por qué no nos planteamos una vacuna para Epstein-Barr?
Es una buena pregunta. Nosotros comparamos con Estados Unidos y ellos tienen el Epstein-Barr en la célula de Reed-Steinberg positivo en un 52%. En Centroamérica o en Guatemala específicamente es el 90% de Epstein-Barr positivo. Podría ser, no sé, una idea. ¿Qué influye? Esto es lo que tenemos también que hacer ahora en adelante. Plantearnos preguntas de investigación. Guardemos tejido, guardemos sangre, guardémoslo. Más adelante van a ser oportunidades, estoy seguro, de poder ver cosas que ahora hacen en otros lugares. Entonces, esto es una cosa que se podría ver.
Un banco de tejido.
Dependerá mucho de cada país, ¿verdad? Pero creo que...
Yo estoy pensando en Salud Global. Carlos, necesitamos un banco de tejido para los 800 pacientes.
Por cuestiones legales, en algunos países el banco de tejido funciona bien diferente. Entonces es una cosa que se va a tener que llevar en cuenta, independiente de cada país. Pero eso no quita que un país determinado tenga un proyecto determinado que no sea generalizado con el resto del protocolo de CLEOR. Si alguien en Guatemala, alguien en Argentina, alguien aquí en Brasil quiere hacer alguna cosa relacionada al protocolo de Hodgkin, lo puede hacer. Es solamente proponerlo para el propio equipo, el equipo interno, digamos. Y yo quería hacer dos resalvas. Estamos comentando aquí con Adriana o que Mauricio está colocando como eu não tenho transplante, eu não tenho PET-CT e Centroamérica, é Centroamérica inteiro. O sea, não é que não tem em Guatemala, mas todas as vezes, então não tem como fazer, a menos que mande para os Estados Unidos, que mande fora do país. Então é uma seleção natural praticamente. E quando a gente se juntou para fazer o protocolo brasileiro, no protocolo brasileiro estão as duas opções. Ou você pode avaliar com PET-CT ou você pode avaliar com CT. O que você tiver disponível. Só não demorar em fazer a avaliação, e se você faz a avaliação com um, você tem que fazer a avaliação, o diagnóstico com um, a avaliação depois com o outro. não adianta isso comparar. Mas, em realidade, a intenção do protocolo brasileiro é mais juntar as pessoas, agrupar as pessoas que não estavam agrupadas em volta de um trabalho que a gente está fazendo em conjunto, que hoje tem 28 instituições no Brasil que estão fazendo o mesmo protocolo. Tá?
Uma observação. Você pode olvidar da ressonância? Vocês estão olvidando? Com DCT,
Não.
a PET-CT, a maioria dos
Não, porque a
países
gente tem guardado essa na manga. Para discutir no final da semana.
Não, mas não se vai DCT a PET-CT, se vai
Sí.
a ressonância.
Así es.
Eu tenho certeza que na Centroamérica
Sí, sí. Yeah.
em todos os países se hace neurocardiologia, se hace linfoma.
Yeah.
Eu estou treinando espanhol.
Henrique Lederman tem um trabalho fabuloso comparando PET-CT. Não sei se alguém já teve a oportunidade de assistir com PET-CT e ressonância magnética. Ele apresentou em Barretos há 2, 3 anos, apresentou em Washington, e eu acho que foi uma apresentação.
Ontem, também no
simpósio do Einstein
Eu
também.
tenho que convencer os oncólogos. Vocês têm que saber que a ressonância, nós só estamos usando o linfoma, ainda não vamos para os outros. É tão boa quanto ou melhor do que o PET. Todo mundo tem. Só o CT sozinho vai dar problema, mas com a ressonância não vamos ter problema.
Perfecto.
Pues, ¿te puedo pedir un favor?
Sí.
Diga por el micrófono que pueden hacer preguntas por internet.
Si alguien quisiera hacer preguntas por el internet, será un gusto para nosotros contestarles.
Que as pessoas não escutam quando eu falo por aqui, eles só escutam se falo por aí. Tá? Raíssa.
Sí, como parte del cuidado de los niños para considerar en el protocolo, sobre todo teniendo en cuenta los procesos infecciosos con el esquema OEPA, que es mielosupresivo, considerar como parte del soporte el uso de factores estimulantes de colonia, sobre todo con el segundo EPA, que ya hoy hay problemas, uso de finastil, por ejemplo, si hay disponibilidad en nuestros países.
Me parece una pregunta interesantísima y hay varios que lo usan, inclusive aquí, pero todavía no sabemos qué vamos a usar. Vamos a discutir qué vamos a usar en el próximo. Entonces, me parece que eso es una buena sugestión dependiendo la agresividad que vamos a tener para nuestros pacientes y la evaluación que vamos a hacer para ellos. Y tenemos que ver quién lo va a tener disponible, porque aquí en Brasil está disponible, en Argentina está disponible, en varios países, que es lo mismo que vaya a acontecer con el arsénico para la leucemia prominocítica.
Sí, Raiza, creo que este fin de semana vamos a decidir cuál va a ser el esquema terapéutico que vamos a usar. Si es el OEPA, COPDAC, aquí está Cristina, ella está en esa. Vamos a comentarle sobre esto y vamos a sacar conclusiones, pero siempre vamos a tener la opción posiblemente. Quien tenga, que lo use, pero ordenar. Yo no tengo, no lo uso, pero vamos a poderlo ordenar y poder saber cómo nos va a ir. Muy importante.
Sí, bueno, felicidades por el trabajo. Yo siempre digo que el ejemplo que daba Oscar al mundo es grandísimo, de cero llevar las empresas casi iguales que en Europa o en Estados Unidos. Debes felicitarte, ¿no? La pregunta es, en este cambio, en los estadios avanzados que hicieron del protocolo del 2012 en adelante, que pusieron el bloque OEPA, yo me acuerdo en la reunión de Nicaragua, en la última, en que realmente las diferencias entre los países eran grandes, ¿no? Nicaragua, El Salvador tenían una supervisión un poquito más baja, y esto habla un poquito acerca de las manejo de toxicidades, ¿no? Entonces, bueno, siendo que Centroamérica es un universo, pero también es un universo muy diferente a Costa Rica, por ejemplo, que tiene trasplante, o Panamá, ¿no? Entonces, ¿cómo les fue a ellos, a los países más pobres de Centroamérica? Porque dentro de los países pobres hay más pobres, ¿no? O por ejemplo Haití actualmente. ¿Cuál es sobre todo la toxicidad relacionada a quimioterapia?
Gracias, Oscar. En lo que respecta específicamente a toxicidad, Oscar, media vez nosotros en Guatemala nos dimos cuenta que el primer OEPA era el que teníamos que tener al paciente cerca. No hubo muertes por toxicidades en los países, aún siendo los más pobres. Logramos transmitirles ese consejo de cuidar el primer OEPA y ahí la toxicidad cambió. Los resultados al final pueden cambiar definitivamente porque depende mucho de que no tenían radioterapia a tiempo, que en lugar de tener acelerador lineal tenían cobalto. Son cosas que han cambiado ya con el tiempo, por suerte. Haití no entró al protocolo, pero lo que queremos ahora en este protocolo, Oscar, es tener claro que si yo no tengo las cosas para dar el OEPA, voy a usar otra cosa. O sea, vamos a tener un brazo, queremos trabajar en un brazo este fin de semana, donde diga, si yo no tengo esto, esto y esto, no voy a usar eso, no me conviene usarlo. Vamos a usar el ABBD, por ejemplo. Y entonces van a evitarse, van a tener siempre mejor sobrevida, pero no va a haber muerte por toxicidad, que eso no es tolerable, ¿verdad? No es tolerable.
Muchas gracias.
Es un gusto.
The next speech is going to be in German.
Some of you might understand, as I heard today, that I have some of German origin. No, I tried to explain everything in English.
Christine is wonderful, a new friend in the house, and we are very, very glad you're here. We had the opportunity to back in Washington, and now you're here in Portugal. And she's going to the Euro data. Some data is secret. That can be okay, no problem with that. Thank you very, very much. We're very glad.
Thank you very much, Alejandro. Thank you very much, Mauricio, and all my friends from here. I'm really very, very pleased and honored to be here at this third CLEOP meeting. And yes, it's also, as I can only echo Ana Maria, it's my first time in South America, but I have already attended one AHOPCA meeting in 2014 at the Dominican Republic, and I think it's a very, very fruitful collaboration, as you have already heard by Mauricio's presentation. So today I would like to give you an overview, or like a history of how it all came to the Euronet group. Also, we started everybody separate in Europe, and of course Germany as a large country and Austria joined to the DAL, Deutsch Austrian Lymphoma Leukemia Group, that was founded by Professor Schellon, one of the M of the BFM from Münster, and he started with the Hodgkin protocol in 1978, in the latest late 70s. And only Germany, Austria, Switzerland, the German-speaking countries joined, but of course there were quite a lot of patients. And then he had the next 5 years the DAL HD82 protocol, which was excellent, gave excellent results. And up to the HD90, Schellung was the chairman, and after the reunification of Germany, he handed the chair over to Dr. Dörfel, who started the HD95, so every 5 years another trial. And only in 95, the NOFO, the Nordic Pediatric Hemato-Oncology Group with Sweden, Denmark, and Norway came in, and also the Dutch Children's Oncology Group. And then there was no more funding with Dr. Dörfel, and he gave the trial back. This is the rule in the German Pediatric Oncology Hematology Society. You have to to raise funds, and then you can get the chair, and then you will be appointed for 5 or 6 years and can do your work. So, and this trial was then handed to Dieter, my husband, and me as a as a vice chair, and we had no money for that, so we only had the will to build something new, and then it grew to a large study. And in 2005 we founded, or many European countries said yes, we want to do a group work, a consortium, a larger consortium, and then the Euronet PHL group was founded, and the first cooperative trial was then started in 2007, and many countries then joined, except for the German-speaking countries, the NOFO countries, also France and UK and Ireland, which had separate protocols. Italy did not join that time because in Italy a new study was started, but Italy is now joining in the second generation, and so also it's no more only European in the second generation. Portugal as a European country joined in, but also Australia, New Zealand and Israel followed the protocol. So now I want to give you an overview how was the backbone. The 78 protocol used the same backbone as in a quite similar as it is today. They used intensification cycle or induction cycles, OPPA, vincristine, prednisone, procarbazine, and adriamycin, and then radiotherapy was put in between with extended fields and adjacent fields, a lot of radiotherapy, and the intermediate and advanced stages got then 4 or 6 cycles of COPP, and this gave a quite good results, but lots of toxicity, as you can imagine. And soon after 4 years, there was the stratification into 3 treatment groups. Patients were stratified according to their Ann Arbor stages into early, intermediate, and advanced stages. And so the early stage patients got no consolidation cycles, whereas the intermediate and advanced stage got 2 or 4. The radiation dose was cut. So the low-risk patients got the highest radiation dose, and the advanced stages got only 25 gray instead of the mantle field and extended field radiation. And you see the EFS rates were excellent, but still a lot of radiotherapy and toxic chemotherapy. But the innovation was only to involved fields, not to extended fields, and they reduced also the splenectomy, the splenectomized patients to a rate down to 40%. And this 1982 trial was then the gold standard because these results were so excellent, but it was known that the whole lot of procarbazine was making the boys infertile, and then after 3 years of the study, they reduced the procarbazine, so procarbazine was abandoned, and only in the consolidation cycles replaced by methotrexate. So OPA-COMP was the treatment regime, and it was seen that after 10 years in the TG1, the rates, those patients only got OPA, no procarbazine, dropped to 85%, so there were many relapses. All these patients could be salvaged in the TG1, but the intermediate and advanced stage patients, they had unacceptable EFS rates of only about 60%. So procarbazine was a really important drug, but for the sake of infertility in boys. So it was reintroduced in the consolidation cycles, but not in the induction cycles. And in the 87 trial, also again the radiation dose was dropped, and the EFS and overall survival rates were increasing quite good, but they never reached again the 90 and over 90% rates. So Shellong then in his last trial, in the 90 trial, he thought of re-intensification of the induction cycles, of the OPA cycles, and he introduced etoposide instead of procarbazine for the boys. Which for the first time rendered this now very famous OEPA cycles. OPA was kept for the girls because in the girls no infertility was seen in that time, so they were not followed long enough, and so there was no fear of premature menopause. It was only then meant that this might be a matter of ovarian reserve, but the girls were not at risk for infertility at that time. That's why the procarbazine was kept for the girls. So in this trial, the 90 trial, which was a revolutionary trial, Shellong's last trial, the radiation dose in the TG1 was reduced from 30 to 25 gray, and the 5 years EFS rate in the OPA treated girls was 91%, OEPA was already at 89%, so also very good, and the overall survival in both groups was at 95%, excellent. So, but still in the COP-treated boys, abnormal FSH levels, so this problem was not solved then. And in this trial, for the first time, central review for staging and response assessment was introduced. Although there was no response adaptation, but it was felt that this was a safer way of going through these trials. And then in the 95 trial, where Döffel became the chairman, the reduction of radiation dose was to 20 gray in all treatment groups, so none of the patients received upfront higher than 20 grays, only if the response was lower or the bulk was not reduced to a great amount. So, and also radiotherapy was omitted in TG1 in all patients that came into a complete morphologic remission. And this was true for all stages of patients from TG1 to TG3. But also then Döffel saw that the EFS rate in the TG2 and 3 dropped, and in the 10 years results, which I will present to you, it was still seen. So taken together the results of these 5 or 6 trials of Shellong, because he followed his patients during his whole life, was excellent overall survival at 20 years of 94%. But as you all know, the secondary malignancy rate tended to increase, and this is for the German the curves. We all know the curves of the COG or the US late effects survey, and we know that they tend to rise, and this is also an example of Shellong's data. He followed his patients, as I said, very, very long. There's a median observation time of 35 years now, and he could also observe an increased breast cancer rate in women later as survivors. They were more than 9 years old at the time of radiation. And this risk is as high as, for instance, for genetic and ovarian cancer in women of the normal population. So this is how the response, I want now to come to how the response adaptation was carried on further in this series. And for the first time, as I showed you before, the 95 trial tried to do response adaptation, but according to morphology criteria. And in the 6th trial series, it was first done anatomic CR after end of treatment, not after early response assessment, and those patients got no radiotherapy in all treatment groups. And these are the data. You can see here the treatment backbone, which was kept on since the second trial. Induction cycles, OPA or OEPA in boys, and COP 2 or 4 cycles for the intermediate and advanced stage patients. And you can see here how the stage distribution is. And if all these patients came into morphological CR, there was no radiotherapy given, and only 20 gray to those that had a good response, or a partial response, or up to more than 75% reduction. That was also evaluated centrally, and you can see the overall survival rate is very good, but the progression-free survival and the event-free survival were less than in the best trials before. And divided onto treatment groups, you can see that interestingly, only the non-irradiated patients did better, not statistically significant, than the irradiated patients in the low risk group. But you can see here in the intermediate and also in the advanced stage patients, the event-free survival rate dropped. So it was concluded that the morphology response, the morphologic response at the end of treatment is not a good marker for good event-free survival. So in the 2002 trial, Mauricio already showed these curves. The radiotherapy at the end of treatment was reintroduced, only not for the patients in the low-risk group, because they had excellent results, as I showed you before. Interestingly, without radiotherapy did better. So that's why also these patients were kept on without radiotherapy. And the novum in this trial was the procarbazine-free treatment for boys. As you can see here, this is the boy cycles. They received OEPA, of course, as before, but in the consolidation, dacarbazine instead of procarbazine. So it was a gender stratified trial, and it was meant to be only a pilot trial, because I told you there was no money for funding, but it recruited so well that about 600 patients could be brought on this trial, and it also took a long time until we got funding for the next trial, and that's why we kept on recruiting. And in the end, it was a good deal that we conducted this trial. And you can see here all 3 treatment groups, even the advanced stage patients, came to an event-free survival of 89% or 88%, so ranging at the 90% margin. But we have to remember 85% of the patient got radiation. And this was also a very good result. This was the main result of the trial, that the OEPA COP-DAC was not inferior to the OPA-COP. But still, it was not a randomized, but a gender-stratified question, and so it was the next question in the European trial. So for the larger trial, we tried to introduce response adaptation at an earlier time point and with PET, as did all the adult groups and the lymphoma world, except for the pediatric world. And you can see here the strategy of this Euronet PHLC1 trial. This patient is a stage 2A patient with a large lump in his right axilla, as seen here in the CT scan. It is PET avid, and after 2 EPA cycles, the PET is completely negative, so no FDG avidity in the previously involved sites. But still, this patient here, seen in the MRI scan, has a mass in his axilla. So he is not in anatomic CR, and in the previous trial he would have gotten radiation, but in this trial not. And this is the study scheme of the C1 trial. So all patients got OEPA. OPA was then completely abandoned, no more OPA. After 2 cycles, they got a response, an early response assessment, ERA, with PET, and all patients in adequate response, namely PET negative, and at least 50% morphological response, got no radiotherapy, no matter in which treatment group they were, and all others with inadequate response, namely PET positive, or less than 50% response, got radiation IFRT 20 grade to the involved fields. And then the randomization question was inbuilt for the TG2 and TG3 because we felt the randomization was gave a higher evidence and not only the gender stratified question. But it was a problem in Germany. The investigators in Germany, they said, why do you do a randomization? We have the results, and it was a problem, I must say. It was, but the randomization rate was quite high, and this is to show you how many European countries contributed. These are all the sites. All the stars are single sites. They contribute to the trial. There's a single star. This is Memphis. Monica and Memphis, they worked together with us for the lymphocyte predominant trial, but not for the classical Hodgkin's trial. And also the Balearic Isles belong to Spain, and of course have also their sites. And these are the new sites for the C2 trial: Australia, New Zealand, Israel. And how can we work in for central review? We have a data network which was founded by an EU grant, and we established this network, which is really an internet-based IT security and data protected way of going. So any site can log in via internet, but of course restricted with password restriction and so. And then the studies are encrypted, as you can see. The images are encrypted after the firewall, and then go to the Telehermes server in Sweden. This is the server, and there the data is decrypted again, but the data cannot go back. So the red boxes mean data cannot go back. And so this is the concept of security. And as you can see here, there is an audit trail for the server activity. And we, as the central review board members, we can log in through our special login, can retrieve the data from the server, and can review the data. And this is, of course, much quicker than the snail mail, the regular mail. The data for the randomized question. So this is not a surprise, and it's not yet published, as Alejandro said, but I have shown it during the SIOP meeting, and so it's no secret again. And it was expected that the COP and the COP-DAC curves will overlay, and this is a very good result. And 1 year before closure of the trial, the randomization was stopped because we saw no futility, so the results were stable. And this was very reassuring that this is a kind of another way plotting FSH levels in a logarithmic way. But you can see green and blue are procarbazine-free treatments, OPA and OEPA and only OEPA COPDAC, and those patients have, in the majority, they have no FSH elevation, whereas 50% of the COP-treated boys, they have elevated FSH levels, and that was reassuring to preserve the fertility in future with the COPDAC, with the procarbazine-free regimen, and now the standard is COPDAC, no more COP. So coming back to the response criteria for the URINET-C trial, what is PET positive, what is PET negative? Those times the Deauville criteria, the 5-point scale, was not published and was not there. It started in 2007 and Deauville came out only in 2010 or 11. And we then used very sensitive criteria. So negative was below uptake below the mediastinal blood pool, and positive was uptake above the mediastinal blood pool, which is now today about Deauville 2 or 3 in between. So we can say Deauville 3 was still positive, and we had a 4-point scale, a URINET scale, and these are the examples. Images say much more than only numbers. So negative was only diffuse uptake, but focal uptake, which would now be Deauville 3, was considered positive, and this is what we all of us can consider positive, not only the nuclear medicine physicians. So the curves for radiotherapy and non-radiotherapy assignment overall. So you can see, interestingly, it seems that it makes no difference, but you can imagine these are all patients in red that received radiotherapy regardless of their treatment group, and it's obvious that the least radiotherapy was given in the TG1, namely only 30 or 35%, but TG3 patients still received about 60% radiation. But very interesting, the EFS rate was the same in the overall in the irradiated and non-irradiated patients, and the best result was that only about 50% of the patients got radiation compared to 85% in the excellent 2002 trial, and that was a major achievement. But still, we were a bit worried how could PET, why did PET not discriminate more between the bad and the good patients? So we thought that it's a quantitative measurement or achieving more better discriminating criteria than the visual. Even the Deauville criteria should be better, and our colleagues from the nuclear medicine group, from the reference group, developed a quantitative method. It's a semi-quantitative method. The nuclear medicine physician detects the positive signal and then apply a computerized program, which is then correlates the maximum signal to the liver, to the average of liver, and this is then the quotient called QPET value. And as you can see here, we retrospectively calculated QPET values from about 800 patients of the C1 trial and plotted them according to the Deauville criteria. Deauville criteria are listed here, and Deauville 1 does not exist here as a histogram because it's negative. There's no avidity. So you can see here Deauville 2 and Deauville 3 overlap very much, and also Deauville 4, which has signals above liver, is still overlapping with these curves. The only curve that is clearly an outlier is the magenta curve, which has very high QPET values and also is related to Deauville 5. And so we saw that we put our threshold for negative and positive in between Deauville 2 and 3, and this was not very good to discriminate negative from positive. And what we then thought, to move the threshold a bit more further, so the Deauville 3 and Deauville 4 discriminated better, and this is where we put now the threshold. And it was also reassuring when we plotted all the signals onto a curve, then we could see it looks quite as a normal distribution curves, and only a few of the patients with very high QPAT values are outliers on this side. So our new threshold of QPAT 1.3, which is then between Deauville 3 and 4, is at the shoulder of the normal distribution curve, and this is still conservative. And we hope that we, in the end, will irradiate only 20% of all patients with this method. And this is these are the objectives in the current trial. And so we want to reduce further the radiotherapy rate. And then we have more negative ERA PET negative patients, namely hopefully 80% in the end. And those patients then will be randomized. All intermediate and advanced stage patients are randomized to different consolidation treatment, because we feel to remove such a lot of radiation might drop the rates, the EFS rates, and that's why we introduced again an intensified consolidation cycle named DCOPDAC 21. It's simply COPDAC plus doxorubicin and etoposide, and given in a 21-day cycle. So intensification for the loss of lots of radiation. And the ERA positive patients, those should then be the really bad responders, the slow early responders, as the COG says. Those patients still will be irradiated in the standard arm, and in the intensified chemotherapy arm, they will be only irradiated in those regions that are still PET positive after the end of chemotherapy. So a new strategy that is kind of a strategy which is mostly followed in adult Hodgkin regimes. And we will have a new treatment stratification. This is also what we have learned from the C1 trial. So we have a new, a much smaller low-risk group, namely only those without any risk factor. We learned from the C1 trial that patients with an elevated ESR and bulky disease treated without radiotherapy had lower EFS, and this is shown here. You can see here, this is the low-risk group. They have an event-free survival of 91%, and it's 11% lower in those patients that are high risk, namely with elevated ESR and bulk. And when we then more subdivided these low and high risk TG1, we could see that radiotherapy, as you can see here in the magenta line, could not save these patients from radiotherapy. Did no benefit to them if they only got two OEPA cycles. They ranged at about 78 or 80%, whereas the low-risk group with radiotherapy had an event-free survival of almost 100%, and the low-risk without radiotherapy are still also at the 90% range. So that's why we introduced in the low-risk group in this current trial another cycle of COPDAC, that the gap will be a bit more closed between the patients that get OEPA and radiation with 100% EFS and those will have had only those with only OEPA had only about 90%. So those will also receive one COPDAC cycle to achieve better EFS. So this is a non-randomized question, but this is an observational question, and the randomization is in the majority of the patients, namely in the TL2 and TL3. And this is kind of a complicated image of the strategy I already alluded to you. Patients are diagnosed, then set up to the central review, and if the stage is confirmed or the treatment level is confirmed, they will get randomized up front, and then they receive their early response assessment. And patients in AR, namely PET negative, in both randomization groups will go to the follow-up after their completion of their chemotherapy, and patients that are ERA PET positive, namely inadequate responders, receive in the standard treatment arm their IFRT, and in the DCOPDAC arm they will only be irradiated according to the results of the late response PET. So only the bad responders at early response receive a second PET, or a third PET if you will, and here for the standard patients, they will receive a boost if they are still PET positive after all chemotherapy, and those patients receive only radiotherapy if they have still PET positive sites. And we saw during the course of this trial, we have now recruited 500 patients already. Yesterday was the 500th patient. We saw that in this arm, the chance of having no radiation is quite high. It's about 50%. I show you, these are the response criteria. I think I can skip that. I show you this table from the first 18 patients randomized to COPDAC. In the table is counted how many sites at initial diagnosis were, how many nodal sites were involved. Nodal sites are depicted in the green lanes here. So up to 17 nodal sites were involved, and at the late response assessment after 4 cycles of COPDAC or 2 cycles of DCOPDAC, in the half of the patients, only no site was positive again, and the majority was 2 sites. So it is really a tremendous effect on PET negativity, and even the extranodal sites, they even respond better, what we saw from the first patients. So it really matters for the radiotherapy fields, shown in this slide here. This is a patient at initial presentation with a mediastinal mass, and this is only one or two coronal slides, transversal slides, and this is the only PET positive sites after all chemotherapy, and you can imagine there is only this small field that gets irradiation, and in the new protocol we can also use proton beams, so radiation will cut down by size and by numbers of sites. So this is the hope. And yes, with the last 2 slides, I want to close, and but not without mentioning our global platform, which has also been mentioned some minutes earlier. And this is really a wonderful platform, which was started by Monica and me in 2011 in Washington, and it was in Berlin, and it just was 1 month ago in the 3rd time in Washington. The next will then be again in Berlin in 2020, and we hope that we will continue with this collaboration, because I think Mauricio, as I understood from my few Spanish words, that he said collaboration is the thing that is the best thing what we can do, and where we have the most efforts and the progress together. And we studied in a group, in our group, Mauricio was also co-author in this review, that our trial stratification is not even comparable. So although we are very major groups, but we differ in what we consider advanced stage. So as you can see, the COG considers 4A as intermediate, and and the Hodgkin Consortium says 2B is high risk, and as we say, 1B is low low risk that doesn't exist in any of the other consortia. So very different stratification, and it becomes even more difficult when we consider response criteria. So this is really worthwhile to work on that and to come to a harmonization, and this has also already started in the SEARCH initiative, which is the staging, evaluation and response criteria harmonization effort, which came out of this platform, and we were able to publish a methodology paper very recently, and this gives us more motivation to keep on with that. So, and I have to acknowledge the funding bodies, but also patients, investigators, families, staff. Without all these people, such effort, such progress and such results were not possible. And I thank you for your attention. And this is Gießen, where I come from now.
I don't know, someone got any question? Please. Juliana, maybe you want to know something about antitherapy there? Cláudio, você que está quietinho lá no fundo.
I took too long. I couldn't.
Não escutei.
Eu acho que a gente pode discutir no futuro para fundir os mesmos critérios.
Okay. He's thinking about just finding the same criteria of diagnosis and evaluation, so we can get we can compare one protocol to another. I think that's a great idea. Now that we can work together with it.
Exactly. Exactly.
Very ambitious.
Yeah.
Any question? Ok, vamos tomar um café. Tem um café lá fora. Mônica já está chegando, está no parcão. Ela vende carro, então vai chegar mais rápido. E aí a gente continua depois, tá? Por favor, se vocês quiserem. Os banheiros ficam saindo aqui na frente do elevador. E tem banheiro para cima e para baixo no mesmo lugar, tá bom? The toilets are right here.